Good afternoon, everyone. We'll start the next session. I'd like to invite Dr. Venkatesh to moderate this session.
It looks too early to start for me. And people are still soaking into their tea and waking up. Anyway, I'll start my introduction to about the speaker for the next session, Dr. Tarun Seem. It was very intriguing for me to go through the CV of Dr. Tarun. Dr. Tarun is a medical graduate from Delhi University. Sir has been the MBBS batch of 1984, I think, in Delhi University. And then after that, sir went to do diploma in public policy and law degree from Lucknow University. And then he has done Indian Revenue Service, an administrative degree. Then he is where he is currently working as a commissioner of income tax. And he has been in great positions in the government of India and in the state of Delhi, and where he has done many reforms, which we are going to hear today about what changes doctor administrator can do to retake the health to the last mile. So he has been a director in the National Rural Health Mission. It's a very privileged post. Then he has been a head of health systems support unit in Public Health Foundation of India. And to say the last and the most, is the director of health service and the secretary of health in Delhi when the Mohalla clinics were instituted, and where sir has been man behind mentoring, implementing this Mohalla clinic, which is a clinic for the neighborhood. And we are going to hear from him a lot about how this his journey through this establishing the Mohalla clinics. I invite Dr. Tarun Seem. Let us welcome with a big hand. Sir, over to you. Good afternoon, everybody. Thank you. You don't hear me? Hello? Yes, thank you. Thank you, CMC. Thank you, Dr. Anand, for this invite. Am I audible now? That's a wrong question to ask. Because obviously, if I was audible, you would be responding. Hello? Yeah. I'm usually not that silly. Thank you, CMC, and thank you, Dr. Anand, for this opportunity. Thank you for a rather elaborate introduction. It's not wrong, but it's not right either. What I'm presenting today is trying to sell a 7-year-old potato to you. That potato is called Mohalla Clinics in Delhi. You must have all heard of it. It is a policy that's of neighborhood clinics that came up some 7 years ago. It took the shape of quite a major health reform in Delhi and now being emulated in many states. But the fundamental principles behind the Mohalla clinics and the reason why it was set up is the story I was proposing to go through. Broadly, my presentation was supposed to be in 3 parts, where I would only touch the urban design of civic services. I would be speaking from the public systems perspective, not the private enterprise, but how the public system is designed, the urban civic design, and how the urban healthcare system is designed, and what kind of service continuum within which the Mohalla clinics were established. My second part would be how medical college or medical students can look forward to this industry and working at that level of healthcare. And the final part would be a more theoretical analysis about how it is so difficult to actually implement what in the previous presentation Harsh was lamenting, and why it's so difficult to bring about equity in an enterprise of healthcare, especially in the public system. So in these 3 parts, I'll try to take you through the story. Hang on with me. Broadly, everybody understand what urban civic design is.
Civic systems in cities are about shared responsibilities. There is no one person responsible for anything. So it's shared roles, shared powers, shared responsibilities. Everything is between many agencies at the same time. So you could be walking on a road of pavement of which belongs to some agency, and the middle of the road belongs to some other agency, which is why you see the potholes, because potholes belongs to a certain agency. So this shared roles can come up as a solution, but this is the design of civic governance in cities. This gives rise to unique advantages of cities. It also gives rise to unique disadvantages of the cities. Everybody knows the advantages. There's a press here, there's judiciary here, there's politics, administration. Everybody is highly sensitive to what is happening. There's higher per capita income. Everybody has mobility. Everybody has knowledge. Access to communication is there. So these are uniquely urban advantages which are not there substantially in rural areas. But then there are unique urban disadvantages. Uh, you don't have a community. The community takes much, it's very transient. It will come one place one day and vanish the other morning. So that rift gives rise to a lot of distress, anxiety, and weak support systems. In this scenario, where we don't have a basic solid social platform and there are many agencies responsible for everything, gives rise to a rather complex matrix of relationships through which a given patient who faces a health event has to negotiate. What happens to the health system? The urban healthcare services also reflect the same story. There are multiple options, multiple agencies providing services. There are many worlds within each one of them. Each one of them could demonstrate the best of the best of the best and the worst of the worst of the worst at the same time in a same single transactions. So we have had, for example, in Delhi, infants died in ICU of in the NICU of a hospital because of the oxygen supply going bad. And probably on the same week was the first liver transplant in Delhi. So you have many worlds which coexist in these locations. The urban healthcare services usually have higher costs attached to them, not just financial costs, but opportunity costs, the decision costs, the loss of wage costs. Uh, there is also something unique in large hospitals in Delhi, for example, and it would be true for any of the big metropolis. Large hospitals would have enormous OPDs. So I have a 100-bed hospital which was designed for 100 inpatients to be taken care of. The faculty positions, the nursing positions, the maintenance, the equipment, the lighting, the seating was designed for 100 patients and an attendant. Such a hospital on an average gets by a factor of 10 to 20 times OPD every day with the associated accompanying visitors. So the whole hospital looks like a fish market, and there is really nobody has any clue about what is happening in the hospital. Neither the OPD outpatient person who's coming is knowing what he wants, nor is the inpatient satisfied with the service he is getting. Also, these hospitals are behemoths. They are confusing institutions where if you have to actually ask the registration counter where you have to go. So the registration counter is going to ask you, where do you want to go? And you say, pet mein dard hai. Now he can decide to send you to gallbladder or to kidney or to spleen. He decides. So the registration clerk really decides what kind of specialty you will flow into in the system. But having done that, you may turn up at a wrong OPD and waste a whole day of transactions. Or even if you end up at the right OPD, you will probably have to come back again tomorrow for a blood examination, which had to be done fasting. And you have to come on the third day to collect the report and the fourth day for the next consultation. So for every health event, the urban healthcare services by design make it rather cumbersome and difficult for a normal average city dweller to use the services. Mutatis mundis, the people who are have difficulties of general life would face these problems substantially more than people who can negotiate their way through the systems. So the equity and disparity is vastly amplified by anybody engaging with the public systems of healthcare in any of the Indian cities. What happened to the concept of neighborhood clinics? So in 2016, there was something a new government had come in Delhi, and it was acknowledged that the grassroots level preventive, promotive, curative care is flatly government responsibility. Corporates or other institutions are not going to uh, provide for that level of care, that level of care at that level. And therefore, this is state territory, and to occupy it, you have to expand you have to herniate your hospitals down into the community and provide the same kind of services without people having to come to the hospitals. The answer, therefore, was a pure medical OPD, which was micromanaged electronically with human mentors to handhold the electronics and information systems for management and compliances. So this took the shape of a neighborhood clinic where the range of services was not important. Where what was important was the guarantee of services. It was not important that we would be able to handle complex medical or health situation, but it was guaranteed that when you will enter, you will be given a seat to sit, and the doctor will hold your hand and give you a greeting, which will be more personal than you are used to. And the instruction that used to go was call them Mataji or call them Didi or call them Mummy and ask them to sit. So that kind of a spirit be there. And then there would be, where would these be located? These would be located in the rented locations deep within the community itself. If there's a slum, there'll be a 2-room tenement which will be taken on rent. If it's a middle class Delhi Development Authority colony, one of the flats would be taken on rent, or half of the flat would be taken on rent. Why rent? Because there is no place where you can actually situate a new government building. There is no possibility of a 450 square foot area to be constructed. Also, these would be minimalistic. They will not be large. They will not have a reception. And you register here, you enter here. It will not be like a passport office. It will be like something that one can easily negotiate and communicate with the doctor directly. They will be staffed by MBBS doctors who would be empaneled, not recruited, not contracted. They would be just told to bring their stethoscope and come and sit in the place and look at the patients. The unique thing about Delhi with all its medical colleges and its urban advantages is that there are a large number of doctors available. Large means a large number of unemployed doctors. Large unemployed doctors means doctors who are preparing for their post-graduation, have time to spare, or doctors who have retired, or doctors who are taking a break from service for family reasons. And that big lot of people were very eager to come and work for 6 hours or 7 hours, 8 o'clock in the morning to 2 o'clock in the evening with just their stethoscope. Everything else the state would provide. The room, the table, the equipment, the machinery. And what do you have to give in return is not any high-end medical care, but a lot of social respite, communication, and counseling. And of course, guaranteed bundle of 100 odd medicines, originally 80, later 100 odd medicines, which would take care of the basic requirements day to day, with a guarantee that your samples would be collected. So the blood tests were contracted out to a NABL accredited lab who would use that place as a collection center. So every morning somebody would come, leave collection bottles over there. The local phlebotomist will take samples, keep them here. The fellow would come in the afternoon, take away the samples and email or SMS the reports next morning. So these would be rented locations with empaneled doctors, with a digital interface between the doctor and the patient. No paper prescriptions, no registers, no card showing, no money giving anywhere, and no national program reporting, no frills about it. Just plain simple medical walk in and walk out with medicines. So I again reiterate, this was the state territory which state tried to reoccupy, that we would take care of primary care, we would take care of preventive, promotive, as well as curative activities required. The 100 medicines would also be guaranteed. There'll be no possibility of any medicine being prescribed which you have to buy from outside. The phrase used was "jo likho wo do," or "jo de sakte ho wahi likho." Nahi to mat likho. Don't write famotidine if you are providing ranitidine. And in any case, we were using generics, so don't use any brands. It is senseless to tell a patient to go buy medicines from outside. This whole structure was scaled up very fast. In about 15 days, we set up 100 such clinics. And there were a lot of up and down arguments and linkages that in case there's a problem, you would refer to so-and-so hospital. So every Mohalla clinic had a small chart that for gynae issues, sent here, for this issue, sent there. So it's not that referred RML. It's like you have to explain to the person that you can't be treated here. Here is the ambulance, please sit in it and go to RML. And the logic was that I should be able to communicate to RML beforehand so that the hospital is expecting my patient. It never worked out. We couldn't mature to that state, but that was the whole logic. This little reform disrupted fundamentally the existing protocols of recruitment, payment, stock movement, laboratory support, reporting, management, anything, any protocols of the government, all of them were violated. So there were audit objections by the dozen. You know, when you guarantee medicines, that means you have to procure it any which way you can. So any which way you can is equal to an audit objection in government. And whatever Harsh might say, you have to survive in the government system. So to make sure there were specific provisions made in the cabinet note to empower the doctor to buy those medicines, and impress cash was given to him to do so. The condition being that under no circumstances will you ask the patient to buy. That would be out of question. This whole initiative was born sometime in 2015 as an architectural innovation, where we said we'll set these clinics up in porta cabins. So we then actually shifted from porta cabins to rented, empaneled, digitally managed Mohalla clinics. And now, as of now, there are about 500 clinics working in a mixed manner, some of them in rented locations, some of them in porta cabins. And they saw about 15 million consultations during 21-22. This is an odd figure. But then I remember in 2016, when the clinics had just started, each clinic was seeing about 100-150 patients a day. And in the morning at 11 o'clock, when you see the total number of, because there's a digital dashboard, and each clinic is showing up on the dashboard, and you say you have seen the 100 clinics, 100 patients a day. So that was a huge expansion of an existing OPD system. These many people would have gone to a government hospital and crowded its OPD. That's what I thought. That's not true. Many of them eventually came out to be opportunistic OPD seekers. In the sense, when lockdown, when demonetization happened, my OPD dipped because they were all standing in the queues outside the bank. But then there would still be a large number of people who would otherwise have crowded government systems, hospitals, looking for OPD attendance. So there was a certain logic that could not be defeated or argued against. As a result of which, the name and fame of these clinics pollinated far and wide. It mutated. Many other states are emulating it. Interesting things came up. Doctors started complaining that it's a shitty place. How can we go and work there? The answer was the community stays there. It is full of filth. That is where the families stay. So you can't parachute into that area and appear to be all clean. Get the place clean. So communication of the doctor with the municipal authority that my area is dirty needs to be made by the doctor concerned. And he would be empowered to do that. Come out of the clinic and stand on the road if there is a infirm person cannot walk in. These are some of the pictures I am just presenting. Another guy coming out on the road and watching. You see, the middle photograph is how privacy gets violated in hospitals. I'm sorry, I couldn't go be worried about the niceties of privacy. We couldn't. These were 2 rooms, and in one day it would get crowded. My job was that this doctor should explain the medicines to the person in detail, how it is to be taken, how it is to be handled. Earlier, we were handing them out by paper. Eventually, we started getting them in envelopes. Small reform, but envelopes need to be procured. So procurement is a complicated issue. Most of the doctors you notice are white-haired. They are young people also, but there are rather old, experienced people who wanted to come and spend some time in those clinics. This platform allows for interesting innovations to be used. That innovation in the middle is the medicine dispensing machine. Somebody invented it. It's available at the airports to give those uncle chips and other things. So they reconfigured the screws to fit in medicine tablets, and This tab of the doctor would be connected to the medicine dispensing machine on Bluetooth, and he would then prescribe and take out the medicine, and the patient would collect it. The interesting thing that was advertised was free posters. The word free was used rather loudly, that there would be absolutely no expenditure of any kind. The principle was that if a patient walks into this clinic and needs a further care, that care would also be paid for by the system. It will not be something that the patient would have to imagine. Statistics showed that most patients were women and children and older people. This kind of a system was used for taking photograph of the patient because we couldn't use Aadhaar as an identifier. So unique identification was done through the photograph, and remuneration of the doctor was on basis of the number of patients he sees or she sees every day. This was a typical 8-inch Samsung tag which was used. Oh yeah, that's one of our clinics which was inundated every now and then, and some very old people who would visit. This was the kind of tab performance which the doctor would see. Total consultation 98 rupees 29840. So this money should come to him by 26th of every month. So assured payments to the doctor was the key to assured services to the customers. That being the logic, that unless we are able to give rational work to the provider and assure rational remuneration, that ethos will not go deeper into the community at the end. Eventually, porta cabins like these came up. Eventually, envelopes like these came up. Eventually, messages like these came up. Medicine not available in the vending machine, because vending machine was an innovation, but it allowed us to sort of, it was just an interesting exercise in learning. It was reported in newspapers and picked up a lot of traction. Now, the key things why such clinics would work and handle equity is because of the numbers, spread, location, timing, linkages, and that fact that they are free and they are patient friendly. They are assured and no documentation required. They are plain, straightforward walk-in, walk-out arrangements. They handle distress more than the illness. Illness is usually self-limiting. Usually. Distress is never self-limiting. It would need a lot of counseling, and therefore that would be, the anxiety would be taken care of as first issue. The challenges we noticed was that it's not only about doctors. There are a lot of other moving parts, a lot of procurement issues, payments issues. You remember the audit objections? There's no end to those. And when a system like this works, because of the high velocity of movement of patients, even if there's a minor disruption, procedural disruption, it amplifies and breaks the entire airframe in one day. So by next evening, you can find out it's all over the press. So it can sort of create an issue. How do you create last mile clinicians? Clinicians who would be ready to operate in a scenario like this. For one, you have to see this clinic as an activity system rather than just a plain clinic. You have to see to it that the teachers and the students have to figure out that they are operating within a care continuum. They have to understand they have fuzzy responsibilities. One day they are responsible for good health. The next day they are responsible for ill health. So everything can come in together in the same transactions. And this is like a bottle with multiple necks. So it's not an easy solution any which way you look at it. But the bottom part of my slide is what I would like to leave the group with, that distress is the actionable cause of action. It is not the illness which brought him. It's the distress that brought him. And illness may be self-limiting, but ownership of the clinic, its design, the way the way the clinic communicates, the way signages are designed, the way medicine supply, laboratory, and those medicine vending machine kind of things work is what makes for appropriate primary health care at the last mile of a public system. I'll very quickly rush you through some innovation that were logically argued. When these clinics were designed, it didn't occur to us, but this is part of a later arrangement that every health clinic is actually an activity system. Activity theory is a research theory. It was set up several years back in Russia, as part of psychology training, but they said every subject aims to do some things to take it to the object with the help of certain tools. And in this triangle, later on, rules and logics and norms were added, and a whole community of people were added, and some division of labor was done between them. So this is how an activity system performs. So if you look at a clinic as an activity system in this diagram, then you realize that the subject, remember the person on the left who is supposed to be doing the work, at a health clinic could be a doctor, could be a healthcare team, could be a vendor, investor, could be administrator, could be a political stakeholder, or could be entirely an external funding agency, say somewhere in Seattle. So to see the clinic as a doctor treating a patient would be a fallacy. It's a group of people who are participating in an activity system where the eventual goal is to serve the patient. The patient also is multifaceted. He could be a patient, he could be community, he could be career growth for the provider team. The doctor wants to get a Padam Shri, so he becomes the object of his own clinic. So there's a bundle of objects, there is a bundle of tools, rules, community, a division of labor. The whole thing is so complex and there are so many threads and dimensions that when all of them engage with each other, you end up what the activity theory calls contradictions. And these contradictions obstruct equity being handled at this level. So the key part of running this clinic or nurturing a last mile clinician is to identify the contradictions and try to solve them. The last mile has to be acknowledged of the health system is a complex adaptive activity system. And you acknowledge equity as a wicked problem. It will not get solved by linear answers. You can't tell the doctors, please be equitable. You have to actually start from the subject to object analysis. Each one of them has to be equitable. Each step of their operation and their organization and methods need to be equitable. Only then would the system be equitable. My last slide. And Harsh, in the previous presentation, pointed out, people say digital will solve the issue. I strongly believe digital would solve the issue for certain reasons. Information system reconfigures equity and disparity in a very, very peculiar way. It gives a very broad view to the managers. I'm not talking about somebody doing e-health or something, but I'm talking about the manager taking a very broad view of the whole territory, planning for procurement of a certain medicine or a certain equipment on a monthly basis at 50,000 locations in the country and having them couriered to them so as to assure delivery. That can be done through information systems. I think that has the effect of reducing ad hocism of local innovation. At some places, people will buy thermometer. At some places, they will not. At Mohalla clinics, one new thermometer will come every month. The previous one would be discarded. That's the norm. That's the standard operating procedure because the system has a checklist and that tick will happen only if that thermometer arrives. It costs 300 rupees. It doesn't, I mean, when we procure in large numbers, it probably costs 75 rupees. But the ad hocism of local innovation, the vested interest, the uncertainty goes away once the information system is used. Also, information systems have concepts of smart contracts. Unlike written contracts, these are self-executing programs where if somebody, like for example, sitting in the control room, one can figure out if metronidazole is being prescribed in the wrong dose, given the weight of the patient that has been just entered in the system. So a smart contract between the doctor and the patient would exist whereby a wrong dosage, wrong medicine, unnecessary lab testing, or avoidable lab testing would be taken care of without anybody actually having to ask a question. So the information really creates what can be called an analog plus decentralization. Decentralization as of now, when we keep talking about health systems getting empowered from bottom up, is going to take the shape of the state abdicating its responsibility. Abdicating its responsibility, which would be wrong. The right thing would be to put in information system and create an analog plus decentralization, which is structured, nuanced, smart, selective, and efficient. This will reduce disparity. This will improve equity on scale, the kind of scale that India needs. So in any other way you try to handle equity and disparity, you would be able to do pilots, but not do it to scale. This, ladies and gentlemen, is my humble submission. Thank you.
Your question. So thank you for that wonderful talk and infusing hope in a hopeless situation that it is possible to bring equity in this world with the disparities. So there are no questions in the system. Shall I invite question from the audience? Yes, please go ahead.
So Tarun, thanks for this, really. I think, for shedding sunshine or, sharing or hope. My small specific question is, you sort of, in your presentation, you circumscribed the role that physicians were to play in the entire subject and object thing, and also the entire design. And but you also prefaced it by saying that this is urban, this is for urban health.
Yeah.
So I thought, and correct me if I'm wrong. I thought that the Mohalla clinic idea, the neighborhood clinic as we call it.
Yeah,
you don't want to use
neighborhood clinics.
So neighborhood clinics were one of the reasons for success was that you had a easy availability of
MBBS
sitting idle
doctors.
physicians, in Delhi there, and maybe other cities in the country. So whether this model is applicable to rural India, where the problems are even larger, and how would that be if is the only stumbling block the availability of physicians, which you are trying to sort of downplay, if I may say?
Actually, Yogesh, what I humbly feel is looking at neighborhood clinics as a method of deployment of surplus human resources is not entirely the correct approach. It's not about deploying the doctor. It's about creating a situation where guarantee of service rather than range of service becomes logical. So if you entirely change the logic and you are able to position a nurse at a rural clinic or a community health worker at a rural clinic to provide respite to the 100 commonest illnesses, including scabies and URIs and whatnot. So rural distress can be taken care of even when there is non-availability of MBBS graduate. Let's de-glamorize the MBBS protocol. It is possible to position, and therefore, and given information systems, you can send all the equipment. All of that is logistics issue. This is no big deal about providing medicines and the other things. It is also possible for you to have bike riders to take your samples from Gurdaspur all the way to Amritsar and get them tested. So technically it is possible, but not per se. And technically, I would not like to put doctors in every village. That, given the scale of India, would it doesn't make language sense, So that, yes, ma'am.
That was a really inspiring talk. I wondered how effective was your referral system when the people had to be moved forth to a next.
Could you say that again?
How effective was the referral system when they had to be moved to a next level of?
It was atrocious. It never worked. In fact, the clinician at the tertiary care hospital would despise the referral made by the remote clinic. So that's what I mean when I say it's an activity system working in a continuum. So there are too many nodes that would need to be reformed. So we try to put ashas at the clinic, at the hospital, that this patient who comes from the neighborhood clinic should go to the asha at the hospital. Asha will hold the hand and take them to the doctor, introduce ki ye udhar se aaya, isko pehle dekho. So the doctor would hold his head off, ki I already have 300 patients waiting outside, you have brought one more. So actually the reform has to be more comprehensive. It cannot be one or two or three or four. So it was pretty bad. It didn't work very well.
Then I think one of the earlier criticisms of Mohalla Clinic was that it is only a clinic-based service, while primary care cannot be only, it's just not OPD.
Absolutely.
So has that moved or changed, or has there been any new development there?
Actually, on paper, it's very easy to say we provide comprehensive health care. You don't. See, if somebody has an acute health situation, talking preventive promotive will not make sense to him. But if he doesn't have stomach pain, then he will not come to you. So you will not have an occasion for doing preventive promotive. So it's a funny balance you have to strike. The first needs to be curative. Somebody has to trust me. And then when I hold his hand, I can tell him, you are smelling of cigarettes. Have you stopped smoking? Why don't you stop smoking? And when his mother is there, so you can ask, ki bacche ka nails kyun bada hua hai? So that preventive promotive has to be knitted together and really not differentiated as three services being provided. That I think is a logical change in the mind of the provider that could happen. But as of now, the clinic is designed fundamentally to be a curative care clinic with all the national programs being taken care of at the dispensaries. The dispensaries already exist. I mean, it's a crowded health system. It's an inefficient, crowded health system. So yeah, that's how it's really working. And it's a 7-year-old potato that I tried to sell you. So,
If there are no
thank you.
further questions from the audience, I would like to ask one question, sir. You said it's a more of a horizontal healthcare delivery, not vertical. So how do you like audit the quality of care? Like the doctor sees and
Yeah, that's
is it with a referral rate? Is it with a number? Is it with a
yeah, that's the key. It's you have to change your logic of delivery of services, then you have to change your logic of monitoring the delivery of services. So, for example, number of patients seen. Sometimes we would see 100 patients being seen in like 3 hours. So, but because the patients were seen on the tab, we will know that you are spending less than half a minute per patient. So the system throws up an alert to the doctor directly. And then if I'm a planner, I can always put in a marker that you would be able to see the next patient only 3 minutes after the first patient has been registered. So you can manipulate performance remotely using information systems. Also, the smart contracts which I talked about, they within the system throw up alerts of quality on a regular basis and self-correct themselves by sending alerts both to the patient or to somebody. For example, a certain medicine is prescribed, which is not available in the counter. So the smart contract will send an alert to the supplier medicine. So that fellow will correct it. So the much of quality issues would get automated and start performing. It's possible to do it. It's been demonstrated as possible. So
thank you,
question of
sir.
scaling.
Thank you for the talk.
Thank you, everybody.
Thank you for the talk. I request Dr. Venkateshan to present the memento to Dr. Tarun.